Video 7, Osteopathic Diagnosis. Fundamental to osteopathy is the concept of osteopathic somatic dysfunction, OSD, or what was traditionally referred to as the osteopathic lesion. This would also correlate to the chiropractic subluxation. Both these terms refer to a situation where a joint is restricted and causing pain, asymmetry, and tissue changes. I've chosen to use the traditional term lesion without the qualification of the use of the word osteopathic, partly for brevity, but also because I don't think any profession should claim ownership of this phenomena. I'm also using it because with the rise of the use of the term osteopathic somatic dysfunction, there seems to have been a fall in the emphasis on sacroiliac joint manipulation. And in this sense, it's also a nod to the pioneers of osteopathy who seem to have paid more attention to this area. I think the neglect of this area has several reasons. One of these reasons is the difficulty in palpation and particularly manipulation of the joints. Manipulating sacroiliac joints effectively, certainly from my own experience, can take many years to get up the steeper part of the learning curve. It's very easy to give up on manipulating sacroiliac joints and use other techniques instead, or ignore the area altogether. Another major reason is the perception that the pain and the joint restriction have to be in the same place. In many areas this is true, but I believe this is not the case in the pelvis and lumbar spine. The pelvis is a closed biomechanical system, and as such, dysfunction of the whole can produce pain in either sacroiliac joint, the pubic symphysis, or the pelvic musculature. I also believe that pelvic dysfunction can then produce dysfunction and pain in the lumbar facet joints and the associated musculature. For that matter, I also believe pelvic dysfunction is a source of dysfunction in the knee, and therefore a host of conditions therein, and even dysfunction higher up in the spine, particularly in the upper cervical spine, and the pathogenesis of headaches. Orthopedic studies would indicate that lower back pain can be affected by anaesthetic injection in the sacroiliac joints, but only in about 15 to 25% of cases. On this basis, it's easy to discount sacroiliac joints as a major cause of pain. However, I believe that although they may not frequently be a direct source of pain, they are frequently a direct cause of dysfunction. In this sense, there may not be symptomatic lesions in the pelvis, but there are invariably structural lesions in the pelvis. Some people refer to primary and secondary lesions. In this sense, I would say that the pelvis is often the source of the primary lesion, even if it's not symptomatic in itself. Accordingly, when it comes to treating lower back pain or pelvic pain, sacroiliac joints in their entirety, as well as the lumbar facet joints, should be palpated and assessed as a matter of course with every patient. The site of pain should be noted, but it should not influence the assessment. In my opinion, reducing a diagnosis to just sacroiliac joint dysfunction or lumbar facet joint dysfunction is excessive reductionism and incorrect as such. Accordingly, the collection of findings in the entire area is more general, but in fact more accurate. At the same time, I believe that a treatment approach involving both sides of the pelvis and lumbar spine is both warranted and more effective.